So I was digging through the research for this deep dive, and one number just kept jumping out at me.
Oh yeah.
10 milliseconds.
That is incredibly fast.
It is, right? It's the speed of the vestibulo-ocular reflex, the VOR. And, to give everyone listening some perspective, your conscious visual processing, the time it takes your brain to go, oh, that's a coffee cup, is about 70 milliseconds. This reflex is 7 times faster than your ability to actually see.
It absolutely has to be. I mean,
Yeah.
if the VOR waited for your thinking brain to catch up,
The world would be a blur.
it'd be completely unwatchable. If you've ever held a video camera while running downstairs, that shaky, just nauseating footage,
Yeah.
that's your life without this reflex. It's a 3-arc neuron shortcut. From the ear to the brainstem to the eye muscles, no thinking, just pure hardwired stabilization.
It really is engineering perfection, and that's, I think, the theme for the start of this deep dive. We think of the ear as just, a funnel for sound, but it's this incredibly precise, high-stakes machine.
It is.
And before we get to the disease, and we are going to get into some really gruesome stuff today, we have to talk about the baffle effect.
Right. And this is just physics,
Yeah.
pure and simple. You've got 2 windows in the inner ear, the oval window and the round window.
And the whole point is that sound can't hit them both at the same time.
If it did, nothing. Absolutely nothing would
They
happen.
cancel each other out.
Exactly. I mean, imagine a tube full of water. If you push on both ends with the same source at the exact same time, the water doesn't move. In the ear, that water is the parallel fluid.
And no movement means no hearing.
Zero hearing. So the whole structure, the eardrum, those tiny little ossicles, is designed to create a preferential pathway, to create a time lag.
So when the oval window gets pushed in,
Compression,
the round window has to bulge out.
rarefaction. That tiny difference, that push-pull is the only reason you can hear me right now.
It's so delicate.
Huh.
Which brings us to the mission for today. We've set up this beautiful clockwork machine. So what happens when you throw a wrecking ball into it?
Then you get chronic suppurative otitis media, CSOM. And wrecking ball is a pretty good metaphor. This is not just a simple earache.
Yeah.
We're talking about a progressive, destructive process that literally rots the architecture of your hearing, and if you don't stop it, can eat its way straight into your brain.
The sources are really clear on the timeline too. We've all had an acute ear infection, but when does it become chronic?
12 weeks. That's
Yeah.
the magic number. 3 months. If you have an ear that's discharging or a hole that isn't healing for more than 3 months, you're not in Kansas anymore. You've graduated chronic disease.
And the damage becomes permanent.
Irreversible.
Looking at the classifications, it seems like there are sort of 2 main camps. You have mucosal disease, and then you have squamous disease. And one of them sound a whole lot scarier than the other.
That's a good way to put it. Think of mucosal disease as bad weather. Involves the main part of the eardrum, the pars pensa. You might have a hole, some discharge. It's not good, but it's usually considered safe.
It makes for a wet ear, but it probably won't kill you.
Exactly. Squamous disease, though, that's the structural rot.
That's the one that keeps surgeons up at night.
It is. This involves the upper part of the eardrum, the pars flaccida, or these deep retraction pockets. And this is unsafe disease because it almost always means one thing is present,
The cholesteatoma.
the cholesteatoma.
This silent destroyer. The notes call it skin in the wrong place, which sounds so harmless until you find out what it actually does.
It's a really deceptive definition, isn't it? It's just disquamated, keratinized, squamous, epithelium-dead skin cells trapped where they shouldn't be.
But it's not just a pile of dust.
No, not at all. It organizes itself into a cyst, a 3-dimensional sac,
A living bag of skin.
a living bag that grows. It has a matrix of living cells on the outside and this cheesy white keratin junk on the inside. And it acts just like a tumor. It expands.
And it seems like nobody can quite agree on how it gets there in the first place. The research lists, 4 different theories?
Yeah, it's a bit of a medical whodunit. You've got Whitmack's theory, which is the most common one. The eardrum gets sucked in from negative pressure and forms a pocket that can't clean itself.
Then there's Ruede's theory.
Basal cell hyperplasia. Basically, the skin cells just multiply and evade. Haberman thought the skin literally crawls in through a pre-existing hole.
Yeah.
And then Sod suggested the tissue itself just changes its mind, turns from mucous membrane into skin.
But no matter how it starts, the end result is the same.
It starts eating bone.
And this is the part I found really disturbing. It's not just physical pressure, it's chemical warfare.
It is. We call it the bone eater for a reason. It uses a triple threat attack. So yes, there's pressure, which cuts off blood supply, but the real damage is biochemical. The cholesteatoma makes your own immune system release these inflammatory cytokines.
Things like TNF-alpha.
Exactly. And those cytokines turn on your osteoclasts.
The cell's designed to break down bone.
Right. So in this really cruel twist, the disease tricks your own body into digesting the little bones of hearing and the mastoid itself.
Which leads to this incredible paradox I was reading about, the cholesteatoma hearer.
Ah, yes. This is something that makes the surgeon's job so difficult.
So break this down. How can a thing that's eating your hearing bones actually help you hear?
Okay, so sound normally travels down the chain of 3 bones: malleus, ginkgos, stapes. The cholesteatoma loves to eat the ginkgos because its blood supply is really weak. So the chain breaks.
And the person should be deaf.
They should have a massive hearing loss. But sometimes they don't, because the cholesteatoma mass itself grows to be so dense and gets wedged in just the right spot that it bridges the gap.
No way.
It physically connects what's left of the malleus to the stapes. Sound starts vibrating through the disease.
So the disease is the only thing connecting them to the world of sound.
And then I, as the surgeon, have to go in and say, look, you have this dangerous bone-eating cyst that could go to your brain. I have to take it out. But when I do, I'm removing your hearing bridge. You're probably going to hear worse after the surgery.
That is just a brutal conversation. I have to break your hearing to save your life.
It is. You have no choice, though. That bridge is a ticking time bomb.
Let's talk about the environment in there, the microscopic battlefield. Because it's not just skin and bone, it's teeming with bacteria.
And the cast of characters totally changes. An acute ear infection is mostly aerobic bugs. They need oxygen.
But a chronic ear is different.
Very different. It's stagnant. It's a low oxygen environment. So the anaerobes, like bacteroids, they take over.
Along with the usual suspects like Pseudomonas.
Right. But the key is the cholesteatoma sac acts like a fortress. It's full of keratin for them to eat, and it creates this biofilm, this slime layer that antibiotics just can't get through.
Which is why eardrops alone don't work. You can't sanitize a fortress from the outside.
You have to physically remove the stronghold. And if you don't, the infection starts looking for a way out.
And this is where we get into the complications. The infection escaping the ear.
Bone erosion is the most common way. It just chews its way out. And you remember the ear is in some very expensive real estate.
The brain is right there.
The brain is above, the facial nerve runs right through it, major blood vessels are underneath it. There's no good direction for it to go.
Let's start with the bone itself, mastoiditis.
So the mastoid is that hard lump you feel behind your ear. Inside, it's supposed to look like a honeycomb, lots of little air cells. In what we call coalescent mastoiditis, the osteoclasts just dissolve those bony walls.
So the honeycomb becomes a cave.
It becomes one big, nasty cavity filled with pus under pressure, and that pressure has to go somewhere.
And I was struck by how specific the names for the abscesses are. It's like real estate. Location, location, location.
It's all about where the bone is weakest. If it breaks through the tip of the mastoid, it tracks down your neck along the SCM muscle. That's a Bezold's abscess.
Okay.
If it goes out the back towards the occiput, that's a Stelli's abscess. If it breaks into the ear canal, that's Luke's abscess. But those are the lucky ones.
Because the nightmare is when it goes up.
When it goes intracranial. Into the brain, meningitis is the most common one, but you also get these terrifying brain abscesses.
And the symptoms depend on where it lands.
Exactly. A temporal lobe abscess, for instance, might cause nominal aphasia. The person can see a pen, they know what it's for, but they just can't find the word pen.
Or they might have auditory hallucinations.
Hearing things because the auditory cortex is right there getting irritated. But if the abscess is in the cerebellum, the balance center, you see coordination problems. The classic sign is something called dystiadochokinesia.
Say that again?
Dystiadochokinesia. It's just a fancy term for being unable to do rapid alternating movements, like flipping your hand back and forth really fast.
They can't do it.
They can't. They also get ataxia. They'll tend to fall toward the side of the lesion.
There's one syndrome in the notes that just reads like a detective novel. Or Grad-Nigo syndrome. This triad of symptoms.
Oh, it's a classic. It's a dead giveaway for petrositis inflammation deep in the tip of the temporal bone. The triad is unmistakable. 1, you have the discharging ear. That's your source.
Okay.
2, deep pain behind the eye. That's the trigeminal ganglion getting irritated. And 3, the real clencher. Double vision. Specifically, the eye can't look outward.
Because the nerve that controls that muscle is getting pinched.
The abducens nerve. It runs through this tiny little channel right next to the petrous apex called Dorello's canal. The swelling just squeezes it. So leaky ear, eye pain, stuck eye.
That's Grad-Nigo syndrome.
That is terrifyingly precise. And then there's the blood clot issue, lateral sinus thrombophlebitis.
Yeah, this is when the infection gets into the sigmoid sinus, a huge vein that drains the brain. It causes a clot, a thrombus. You might see something called greasing or sign swelling over the mastoid because the little emissary veins that drain the scalp get backed up.
And there's this old school diagnostic test mentioned, the Tobiera test. It's brilliant, really. You do a spinal tap to measure CSF pressure. Then you press on the jugular vein on the healthy side. The pressure should shoot up.
Because you've blocked the drain.
Right. Then you press on the jugular on the infected side. If there's a clot already blocking it,
Nothing happens.
the pressure doesn't change. It confirms the blockage. Nowadays, we just get an MRV, but the physiology is just so elegant.
So let's talk about the detective work, the diagnosis. How do we find this before someone is seeing double?
Well, it starts with just looking in the ear. If you see angry red granulation tissue, you have to figure out if it's a surface problem or if it's coming from deep inside. We use something called sigillization.
The little puffer on the otoscope.
The puffer, yeah. If the eardrum moves when you puff air, it's probably just surface inflammation. But if that eardrum is stiff, totally immobile, something is holding it from behind, that points to CSOM.
And then you bring in the big guns, the CT scan.
The CT scan of the temporal bone. It's the gold standard for looking at bony erosion. And radiologists have these great little signs they look for.
I saw the ice cream cone appearance.
That's the classic. On one of the CT slices, the head of the malleus bone looks like a scoop of ice cream, and the body of the incus looks like the cone. They should be nestled together.
And if the cone is gone?
If the cone is eroded or missing, that's the cholesteatoma's handiwork. Then there's the snake eye appearance.
That's in the balance canals, right?
In the superior semicircular canal, yeah. If you see 2 little dark spots like snake eyes, it means there's a fistula. A hole has been eroded into the balance canal itself. That is a surgical emergency.
And finally, the hearing test, the audiogram. There's a trap here called interoral attenuation.
Oh, it's a huge trap. The skull conducts sound really well. If I put a headphone on your bad ear and play a loud sound,
Your good ear will hear it.
your good ear will hear it right through the bone. We call it crossover. With bone conduction, you lose almost no sound intensity crossing the skull. So if you don't mask the good ear play static into it to keep it busy, you might get a reading from the bad ear that looks okay.
But it's actually stone deaf. The good ear is just doing all the work.
Exactly. You could misdiagnose a dead ear as having function if you're not careful.
So to bring this all together, we've gone from this absolute miracle of the VOR reflex, keeping our world stable in 10 milliseconds, to the slow, grinding destruction of that very same bone.
It really puts a runny ear in perspective, doesn't it? We tend to just think of it as an annoyance. But CSM, it's a silent siege. It's a fortress for bacteria expanding inside the temporal bone, and it's recruiting your own body to tear down the walls that protect your brain.
And the part that really gets me is that it can be invisible.
And that's the concept of masked mastoiditis. And that's really the thought I hope people take away from this. You can have a patient with an eardrum that looks pretty normal, maybe a little dull, no big hole, no river of pus.
But behind that wall,
Behind that wall, the mastoid honeycomb is being completely destroyed. The absence of evidence is not the evidence of absence.
especially not in the temporal bone.
Not there. It's just a reminder that some of our body's most dangerous fights happen in total silence, just millimeters from the very things that make us who we are.
On that sobering note, thank you. This was an incredible tour through the ear's architecture and all the things that threaten it.
My pleasure.
And for everyone listening, take care of your ears. We'll see you on the next deep dive.